Hello, everyone, and welcome to the webinar, Addressing Key Preventive Health Measures in Homeless Healthcare Settings. My name is Molly Mindbress, and I will be acting as moderator and host for today's webinar, which is a production of the National Healthcare for the Homeless Council, with support from the Health Resources and Services Administration, OSPH. This is a one-hour presentation with the last 10 minutes reserved for questions and answers. A selected number of questions will be answered at the end of the presentation during the Q&A session. Thank you for participating in this webinar. Today's session will focus on integrating clinical preventive services into primary care visits within the homeless healthcare setting. Key morbidities and causes of mortality among those who are homeless include cardiovascular disease, infectious diseases, substance abuse, and mental health issues. However, providing recommended preventive services to those who are homeless can be challenging, with patients who present with acute care needs and working in treatment settings with limited resources. A new publication from the HCH Clinicians Network, Healthcare Delivery Strategies, Addressing Key Preventive Health Measures in the Homeless Healthcare Settings, responds to this issue by highlighting 14 preventive services that can have high impact for patients who are homeless and are feasible for resource-poor settings. Our presenters will describe the challenges in providing preventive services and will use case examples to show how these healthcare delivery strategies can be used in your practice. Our first presenter is Greg Morris. Greg has worked as a physician assistant at the Vista Homeless Health Center in Colorado Springs, Colorado for 17 years and has been the HCH program director for the past 7 years. He was awarded the National Humanitarian Physician Assistant of the Year in 2002 for sleeping on the streets with his homeless neighbors and instituting a mobile medical outreach van to the local soup truck. In 2009, Greg developed a mobile medical van rural outreach program, and just this year became founder and executive director of the new Ascending to Health respite care program in Colorado Springs. He has been on the HCH Clinicians Network Steering Committee since 2008 and currently serves as chair for this committee. Our second presenter is Dr. Monica Bharel. Dr. Bharel is the medical director at Boston Healthcare for the Homeless program in Boston, Massachusetts. She joined the Boston HCH program in 2003 and has many years of experience in caring for vulnerable populations in both outpatient and inpatient settings. Dr. Bharel is also an instructor of medicine at Harvard Medical School, Massachusetts General Hospital, and an assistant clinical professor of medicine at Boston University of Medicine, Boston Medical Center. Her areas of interest include preventive health care and chronic disease management for underserved populations through system-based improvements. Her areas of research have included cervical cancer screening in homeless women, hepatitis C in vulnerable populations, and medical education. Dr. Bharel is currently completing her master's in public health degree through the Commonwealth Fund Harvard University Fellowship in Minority Health Policy. I will now let Greg Morris begin the presentation. Greg?
Good evening and welcome to our webinar. I'm sorry, that was a seasonal opening and I promise that will not happen again during this webinar. Thank you, Molly, for that introduction. Now I will go into a quick overview. Today's overview includes an introduction and the difficult task of implementing preventive services in the homeless clinical setting. Also, how the preventive medicine guidelines were developed, including the panel selected, comparisons to select United States Preventive Services Task Force guidelines, and selection of measures important in the clinical setting. In this webinar, we have selected for discussion a few case scenarios in which implementing preventive measures early can enhance chronic disease management and offset potential complications later, and hopefully how to do this without sacrificing valuable time. I am very pleased to be a part of today's topic and to present with Dr. Monica Bharel. I really jumped at the chance to participate in the development of this topic as I find it very difficult to find the time and resources to implement consistent preventive measures in a small clinic setting like ours with an ever-increasing patient base and growing demands on time. So let's start with the levels of preventive care. First, there's primary, in which you optimally want to prevent the disease from occurring. There's secondary prevention. The disease is present and the focus is on preventing complications from developing. And tertiary prevention. The disease and the complications are present and we would like to ultimately prevent further deterioration and worsening of morbidity. The United States Preventive Services Task Force is composed of experts in the field of prevention and primary care. They provide recommendations for improved outcomes for children, adolescents, adults, and pregnant women. But the issue is the problem is one size does not fit all. What is apparent to the United States Preventive Services Task Force as prudent preventive screenings is not always feasible in the resource-poor homeless setting. Barriers to preventive care. From a patient perspective, they are numerous. There's lack of transportation, preventive health issues, a different set of priorities, competing appointments, substance abuse issues, employment, and access to healthy food. These variables, just to expound on that, just for a homeless person to make it into the clinic setting can be a barrier. There's decisions constantly evolving. Do I keep a Social Security disability appointment or do I try to get lunch knowing that logistically it can take most of the morning to get to that lunch? Or do I look for a job and try to obtain income on getting off of the streets versus taking care of my own health issues? Then there are barriers to preventive care from a clinician's perspective. There is insufficient time, lack of staff, insufficient time, lack of resources, and did I mention insufficient time? How many issues are we addressing today? Can be a barrier from a clinician perspective. Has the person been in the clinic, has not been in the clinic for several months? Do we need to refer this patient to a specialist based on a previous appointment? Is there enough staff to do the screenings, or is patient flow and provider patient support only done with limited staff? And if you take a look at the blue box, and I had to take a double take on this stat myself, it would take, according to the American Journal of Public Health, clinicians 7.4 hours per day to follow every guideline in the United States Preventive Services Task Force recommendations. And I think to expand even further, they alluded to approximately 1,150 clinic hours a year. That's just phenomenal. So how can you do this with everything like this hanging over your head? The only reason why I can do it is because I have 4 people holding everything over my head. The importance of prevention. Many manageable health conditions are poorly controlled in individuals who are homeless. Clinicians often encounter patients who are homeless at the secondary or tertiary level of care as part of their initial presentation. Not being able to do basic prevention can lead to development of complex comorbidities, resulting in frequent hospitalizations, ending in a life expectancy that is roughly half that of the general population. That last one is really a focus of mine. To expand on the numbers, the research shows that the average homeless person can expect to die 30 years before their housed counterparts. You can throw any other number out there, that's associated with homelessness, like 10 years to end homelessness, or 736, the amount of minimum wage that is not enough for supportive housing. But the 30 years, from a healthcare standpoint, is an absolute travesty to me and needs to be addressed. And hopefully we can do that through a little disease prevention. Here's what we know. Health disparities exist in the population of those who are homeless or unstably housed. Low socioeconomic status and living conditions have a direct influence on health, contributing to infectious and chronic disease, injury, and negative impact on child development. Much research documents the health needs of homeless, but there are few resources providing guidance on prioritizing preventive care services. That is certainly the focus of this very guidance. Here's the guidance for HCH clinicians and why it was developed. In 2008, the Healthcare for the Homeless Clinicians Network identified integrating preventive medicine and primary care as a high priority. The goal is to develop a guidance to help HCH clinicians prioritize preventive health measures and to be able to address these during the typical clinic setting. So basically from the front lines came a cry that we would just really like to be able to provide preventive medicine in a very busy clinic setting, and can you help us really develop what's important and what's not, how to effectively screen and prevent disease in an arena full of existing and poorly controlled multimorbidities, dual diagnosis, and other barriers to prevention. So the goal is to help develop this guidance. But you have to stop. Alto, stop. These recommendations by the task force in no way obviate the obligation of clinicians to perform any screening available and recommended by the United States Preventive Services Task Force, even though it takes 7.4 hours a day to do so. Here's the methodology. Literature review conducted exploring the relationship between, and a literature review was conducted exploring the relationship between homelessness and health and key morbidities and mortalities. We created a preventative medicine task force consisting of clinicians from Healthcare for the Homeless projects across the country, along with vital support from National Healthcare for the Homeless Council staff and an intern. Reviewed literature to identify and prioritize preventive practices in the healthcare for the homeless setting. So this resulted in several monthly teleconference meetings trying to extract what is a priority screening measure in one project and what was not in another. What was surprising to me is the difference in the available staff and resources to carry out screenings from one project to another demonstrated a huge disparity across the country. Here are the results of the literature review. Homeless individuals are at greater risk for health-related issues, and that approximately 50% of the homeless have significant mental health issues, and 25% of those have serious conditions such as depression, bipolar, and schizophrenia. What this did was, and all of this plays a factor in implementing effective preventive measures in the clinic setting. And also, if you look and if you work with the homeless on a consistent basis, these numbers demonstrating the mental health issues really seem and feel like much more than these estimates. And continuing with the literature review, we looked at housing status, how housing status impacts social relationships and access to care, how conflict of dealing with competing appointments and systemic structure barriers within the healthcare setting. Developing the recommendations. The Preventive Medicine Task Force conducted an evaluation of the United States Preventive Services Task Force recommendations for 2010 for general and special needs populations. Each recommendation was scrutinized and rated using the following criteria: impact of care, resources available, and potential barriers. What this did was it resulted in a narrow list of potential screenings prevalent to most healthcare for the homeless clinics, and we felt could be implemented in a standardized manner. And continuing with the developing of the recommendations, the Healthcare for the Homeless Preventive Medicine Task Force also identified preventive measures not present in the USPSTF recommendations based on high prevalence and health outcomes in people who are homeless, and also funding stream requirements. Prioritizing the preventive health measures. We developed a detailed description of 14 preventive health measures identified as high priority. We provided a side-by-side comparison of the United States Preventive Services Task Force and the Healthcare for the Homeless Preventive Medicine Task Force recommendations. This resulted in a comprehensive review listed in the Healthcare for the Homeless Preventive Medicine document. Sometimes we agreed with the United States Preventive Services Task Force, sometimes we did not, but we offered suggestive screening alternatives. And then this is the list of the 14 preventive measures that were common across Healthcare for the Homeless projects that we felt could be implemented with suggested screenings in the patient population. So we looked at cardiovascular disease risk factors, blood pressure screenings involving blood pressure, hyperlipidemia, and diabetes. We looked at depression screening, intimate partner violence screening, infectious disease, including hepatitis C, HIV, tuberculosis, chlamydia and gonorrhea, immunization delivery, substance abuse, looking at alcohol misuse and illicit drug use screening, tobacco counseling, and intervention. And actually, these are basically the 14 measures that bubbled to the top. And we'll look at highlighting prevalent clinical issues seen in the healthcare for the homeless setting. This individual here actually just found out that I would be her medical provider, and I'm trying to console her. Actually, how often does an encounter start in this fashion? When trying to care for patients with multiple health issues, this encounter has already gone in a different direction. This may not even be the reason why the patient came to the clinic that day. So any ability to address chronic health concerns is jeopardized by the current instability of her mood. There are so many factors at risk during this juncture of the encounter, including compliance, follow-up, and general physical stability of those homeless with chronic health conditions. Being able to implement a simple depression screening prior to this visit could have prevented this type of encounter and possibly of not being able to focus on her health concerns that day. For those with the resources, and probably I'm living in a bit of utopia, a referral to the clinic behavioral health specialist for immediate evaluation would be optimal, with instant collaboration on an effective treatment plan and then follow up closely to ensure the efficacy of that plan. Again, and ideally, we would like to prevent this situation from occurring. The key is early diagnosis through effective depression screening. This could be done with the referral to the behavioral health specialist when the patient presents with specific symptoms, or the use of provider-driven depression screening tools if behavioral health is not accessible. Also, frontline staff can be trained to initiate a depression screening protocol based on patient history and presentation. This is a good way of doing the depression screenings in a time-sensitive world of homeless healthcare. Effective and early depression screening in the homeless population can help evaluate treatment potential and hopefully control the depression. This can have a positive effect on follow-up in general and the ability to address chronic health issues as well, especially if a poor compliance history is related to the deleterious physical effects of the poorly controlled mood. This is depression. In 2003, the Healthcare for the Homeless User Survey reported 42% of respondents greater than 13 years of age experienced at least one symptom of depression in the previous month. 20% of those surveyed had unmet mental health needs, yet only 7% of Healthcare for the Homeless patients have depression as a primary diagnosis, likely due to the inability to perform consistent screenings for various reasons. So if 42% of Healthcare for the Homeless users experienced one symptom of depression in the previous month, why are only 7% are known to have depression as a primary diagnosis? Preventive screening measures, even if implemented by the front staff, can get the depression on the radar, evaluated, and treated. While it is important to provide early and effective screening for depression in the homeless population, it also needs to be listed as a diagnosis to ensure continuity of care is continued. Continuing with depression, homelessness is a significant stressor on physical and emotional health. The Healthcare for the Homeless Preventive Medicine Task Force agrees that depression screening should be a part of preventive care. Barriers are initially related to the lack of resources, cultural beliefs, and lacking integration of care. And I kind of threw this last one on there because I believe in 2005 I was actually trying to get a grip on how many really did have mental health issues in the clinic, and this was before we had electronic health records. So we actually had a paper intake form that had boxes to check. Out of 1,250 patients in 2005, 426 checked mental illness, 302 checked substance abuse, and 226 checked both. So that roughly shows 75% of those responded admitted to mental health, substance abuse, or both. And I think that the results are higher than the accepted stats in the homeless population, especially if you consider that substance abusers are often self-medicating for mental health issues. Finishing up depression. Depression transcends all healthcare for the homeless projects. Proper screening and control of depression can have a profound effect on early diagnosis and control of other chronic illness. Staff-assisted depression care supporters should be prioritized to enhance accurate diagnosis, treatment plan, and follow-up as part of our recommendations. And now, I believe you are probably very tired of listening to my voice, so I would like to pass the mic on to Dr. Monica Bharel for some case presentations.
Thank you very much, Greg. I would like to start with a case. I want to highlight that one of the reasons that we started our discussion with depression is it was very striking during our task force discussion how important it is to deal with the mental health and behavioral health issues of our patients and how that may be different than other clinical practices. The case I'm going to speak with you about now is a 51-year-old male, again with very significant behavioral health issues. He's a patient I saw at Pine Street Inn Clinic here in Boston with a history of schizophrenia that was untreated and asthma. And he was seen in the shelter because of symptoms of upper respiratory tract infection. The clinic nurse, before I saw him, documented an elevated blood pressure at 145/96, a body mass index of 28, which is above normal, and a blood sugar of 300. Part of the reason I wanted to focus on this case is, Greg mentioned the issue around how much things we have to do as providers. And this is not only in healthcare for the homeless programs, but as primary care providers nationally, there's a lot to do, and nobody has the 17 hours that it takes to take care of everything that we need to do. So how can we then figure out ways to creatively do what needs to be done for our patients to improve that horrible age of death that Greg is referring to, and take into account that our patients have these complex behavioral health issues, addictions issues, and multiple medical problems and social determinants of health that they're dealing with. So one of the ways there's a lot of us have been doing for a very long time, there's a new, although be it a very old concept of patient-centered medical home. And many of us are hearing about it now. The national discussion around primary care reform speaks about it a lot. And in that discussion, a lot of the concepts of it, if you read about it, are things that we have done for a long time in our programs. So engaging other members of the team, other than the provider, in order to get these many things done is going to be critical, and many of us have been doing it for a long time. So in this particular case, the nurse had a standard checklist of things that she checks. So she checks the blood pressure, she checks the BMI, and then based on those being high, checks the blood sugar. And that's really helping the provider take care of this very sick patient. So another reason to focus on diabetes and diabetes screening is it's lunchtime, so I hope this isn't making you too hungry, but this is the delicious meal that many of us are used to, our patients receiving, and though for sure, this plate does have some carrots and a small amount of greens on it. Most of our patients are eating a lot of inexpensive, nutritionally low calorie-dense foods. Greg spoke about different kinds of prevention, and there's a primary prevention technique really speaking to our patients about portion control and speaking and advocating with our shelters about ways in which, in a cost-effective manner, meals can be changed for all of our patients is really a critical point for us all to be thinking about. As HRSA has now recommended BMI screening for all, our numbers at Boston Healthcare for the Homeless show us that a striking 85% of our patients, 85% have abnormal BMIs. So there really is a lot of work to be done in this area, thinking about the quality of food and the quantity of food that our patients eat. Given the issues related to food insecurities and all of the other income and social issues that our patients deal with, it's not an easy topic to broach, but really an important one given the prevalence of obesity and diabetes that we're seeing in our population. So for diabetes screening, the recommendations that the task force looked at, we basically are recommending our recommendations based on, again, the U.S. Preventive Health Task Force and the American Diabetes Association. And this includes screening of first-degree relatives with type 2 diabetes, certain ethnic groups and minority groups who are at increased risk, such as African Americans, Hispanics, Asians, Pacific Islanders, or Native Americans, individuals who are overweight, defined as a BMI 25 or higher, and individuals with cardiovascular disease, which includes hypertension. So thinking about the patient that I presented to you, he did present with an impaired glucose tolerance. His age was above 45. He did not know his family history. He had an elevated BMI, which I told you about, sedentary lifestyle, which is a real issue for many of our patients. He was an Asian man with an elevated blood pressure, and I did not have his triglycerides. That particular individual, he was challenging because he was untreated for his schizophrenia, and after about 6 or 7 visits, we convinced him to start taking treatment and have done a lot of education with him. But these are our recommendations for diabetes screening, which, as many of us know, are really, it's an increasing issue for our patients, especially with the current obesity issues that we see. Moving on to another question, another case. This patient is another patient that I saw, a 28-year-old female who came to our clinic to be, quote unquote, medically cleared for an admission to a detox facility for injection heroin use. This may be a case that's familiar to many of you. Now, she was offered, when she came in to be medically cleared, she was offered several screening tests, including sexually transmitted infection testing, Pap smear, hepatitis C, and HIV testing. We have incorporated many of these tests whenever we see a patient in order to try and, again, catch people when they come in for specific issues and then wrap the preventive services around that visit. All of the tests mentioned above came back negative except for her hepatitis C test, which was positive. The hepatitis C test at our institution takes several days to come back. Luckily, because I knew the detox center that she was going to, I was able to call that detox center and inform her of the test and have her come back in. So hepatitis C. So studies show that the rates of hepatitis C in individuals who are homeless is 17 to 45%. In Boston, we looked at a retrospective study, yet unpublished data, and found that about 40% of our patients are seropositive for hepatitis C. So if you think of that, that's an enormous, enormous prevalence of hepatitis C. In the general U.S. population, the prevalence of hepatitis C is 1.6. So our patients as a whole are at tremendous risk for this disease. So the U.S. Preventive Task Force, you can imagine, recommends against routine screening of the general population for hepatitis C, but says to screen those at quote-unquote increased risk. Because of the prevalence of hepatitis C, this is a good example of one of the diseases where the task force felt the general national guidelines are not sufficient for our patients. We recommend offering hepatitis C screening to all youth and adults due to the very high prevalence, whether or not they state that they have a risk factor for hepatitis C. And in the same way, that patient I just spoke to you about is somebody who was screened. She had an obvious risk factor, but we screen all patients because we often pick up cases that we were not expecting. Hepatitis C, why screen early? So, early referral for treatment is very important for patients with hepatitis C. It's very well understood that many of us do not have the resources to refer to specialists. And in fact, if you look nationally, only about 30% end up going to specialists and less than 4% complete antiviral treatment. So talk about a healthcare disparity. Only 4% is a treatment available and only 4% are getting it. That's like saying somebody has strep throat and only 4% are getting the penicillin. I mean, there's really important treatment that can cure a lot of individuals that our patients are not having access to. In addition to being able to refer patients early on, another important aspect of finding out if someone is hepatitis C positive is because we, as primary care clinicians, are able to then vaccinate them against hepatitis A and B in order to prevent a hepatitis A or B infection on top of their already hepatitis C infection. Additionally, knowing that they're hepatitis C, we can counsel them on very important hepatotoxic agents that a lot of our patients are exposed to, including Tylenol and alcohol. I have found that having the unfortunate new diagnosis of hepatitis C has helped several of my patients become more motivated to stop drinking, and I'm sure you've had this experience as well. And finally, even if our patients are not able to get the referral and the treatment they need, we then know to monitor them for the consequences of the hepatitis C, including cirrhosis and hepatocellular cancer. And depending on your practice, in our practice, we see a lot of cirrhosis and hepatocellular cancer. And hepatocellular cancer is our number 2 diagnosed cancer in our group of homeless individuals, the number 1 being lung cancer. Let's move on now. Greg mentioned that we discussed 14 areas of focus. And another area of focus, when we spoke as a task force, a couple of things really struck me. The behavioral health issues, the really profound behavioral health issues were highlighted again and again, as well as the issues that our patients struggle with around substances. And any discussion of prevention led to the discussion, well, we're also dealing with these. So they can't be the elephant in the room that's not addressed. We have to figure out how to address them at the same time as all of the other preventive health issues we're speaking about. So let's look at alcohol. So alcohol use in individuals who are homeless ranges from 58 to 84%. I know on some days it feels like 100%. And if you look at the U.S. Preventive Task Force, actually, our recommendations concur with them, and these are recommendations for brief screening interventions for all adults, including pregnant women in primary care settings. So the U.S. Preventive Health Task Force and ourselves both agree to screen all adults. I should say as a side note, some of the data that we're quoting in this, the references are all listed. If you look online at the National Healthcare for the Homeless site, you will see our full and detailed report of what we're doing here is a really brief summary of the extensive report that we did, and it includes references and useful tables that go over all 14 of our measures, as well as the U.S. Preventive Health Task Force measures. So this, I apologize for the tiny print, but I just wanted to give you an example. At Boston Healthcare for the Homeless, we do use an electronic medical record, and as part of our electronic medical record, we have put in clues. So again, going back to what Greg said earlier about the time stresses that we have, we need a way to make it as easy as possible for clinicians, not just providers, but all clinicians, to be able to assist with this screening. So if you look at this risk factors form that we use, at the very top, you'll see here, it talks about tobacco, which I'll get to in a second, but then alcohol use. And when you click on a current user, these next set of questions, there are 3 questions listed under the red bar. And those are the Audit C questions. And these Audit C questions are validated questions that can be used to pick up on hazardous drinkers and active alcohol use disorders. So if somebody in our organization clicks current alcohol user, then these 3 questions come down, and based on the score, you can tell if someone's at risk or not, and then do further intervention either yourself or, again, in an ideal situation, if you're lucky enough to have somebody to help or that you can refer to, referring to that person. Again, I want to bring up the concept of all of us, whether you're doing it formally or informally, to get involved in the concept of patient-centered medical home. When the national discussion talks about ways to reform primary care, a lot of the key features of what should be done are things that all of us are doing already. So how can we show that the best way to take care of homeless individuals is the methodology that we've come up with and the way that we figured out to work in teams and to work together and to be patient-centered and to go to where the patient is to provide the care that they need. And I think as a national group, it's going to be very important for us to highlight that as healthcare reform moves forward. So looking at tobacco, Greg talked about the early age of death and how, that keeps him up at night. So when I think about tobacco use in our patients, this is something that I just want to go and scream outside on the streets. So tobacco use in individuals who are homeless is over 70%. There have been national studies looking at tobacco use from surveys in homeless individuals, and it's 73%. And our internal numbers from internal studies at Boston Healthcare for the Homeless show over 70%. And in fact, if you count people who used to smoke, then it's even closer to 80%. So really a large majority, almost all of our patients are either prior or current smokers. And when you think about the history of tobacco use, if you want to get impassioned about a healthcare disparity, if you think about the history of tobacco use in the United States, after the Surgeon, at the time before the Surgeon General's report came out in the 1960s, most smokers in the U.S. were actually upper class, well-off individuals. As that report came out, more and more educated, higher means individuals stopped smoking, and the tobacco industries in the tobacco industry in the 80s and 90s began specifically targeting people of lower means, including homeless individuals, to the point where now we're at this number where it's over 70% of our patients smoke. So really, studies show that our patients want to stop. And I think another stereotype, which we all know is not true, is that homeless individuals don't want to stop. It's not that there's not a lot of barriers for them to stop, but the desire to stop is there. And HRSA recommends to all of us to screen for tobacco use at least twice a year. And we recommend screening in all adults. Again, as a trigger in order to help, as many mechanisms that can be put into place to trigger people's memory, to help different levels of staff, to help us in this. Is it possible for a case manager or an MA who's signing a patient in or a nurse to do this part of the screen so that when it comes back positive, somebody else can help? At Boston Healthcare for the Homeless, we've used volunteers, including AmeriCorps volunteers, and done some basic training with them on tobacco cessation so that they can do individual and group sessions on tobacco cessation. Again, a way to take the burden off of just the provider and really have a whole group of individuals caring for all these important issues related to our patients. So again, if you look here under the blue bar, it's tobacco use, and it's if you click off current everyday smoker, it kind of triggers you to talk about whether you counseled them or not, referred them to cessation programs, and then give a little bit of history of how much they're smoking. I'd like to go on to another case, and this is my last case. This is a 42-year-old female who was admitted to our medical respite for a broken ankle after falling. During her respite admission, she was offered routine screening per the guidelines, including a pap smear and a mammogram. She had no palpable lesions on exam and no symptoms. Her mammogram came back abnormal, and she was diagnosed with early-stage breast cancer and successfully underwent curative treatment. I bring up this case not to highlight the 14 or so issues that we talked about in the task force, but to highlight again the importance, Greg mentioned it several times, of really wherever we can trying to adhere where the resources allow to highest standard of care. It's really important to us to provide very high, the best care we can for our patients. That's why we all do the work we do. But what are creative ways in which we can do it? So one of the things that we've started to do over the last few years is when somebody comes in, for example, as in this case, to medical respite for a broken ankle, to really, while we have their attention and we have the ability to do things at the respite like pap smears and mammograms and the appropriate screening blood tests and counseling, to do those while we have them. We switched to a model of, wherever possible, offering a woman pap smears when she comes in for a cold or a cellulitis or some of the other common things we see. And based on that, we've been able to double our PAP screening rates and really picked up a lot of important abnormalities. So I just wanted to emphasize that point to really think about where we can creatively do screenings and prevention where other people may not. When I myself go to urgent care or take my children to urgent care, none of the preventive health issues are addressed because there are other forums in which to do that. We all know that with our patients, sometimes when you're seeing them for the cellulitis or the broken ankle, it's the only time that we're able to engage them. So how can we, again, creatively say, we have this long list of preventive health issues that we need to deal with. Where and when can we do them in a way that is patient-centered and appropriate for our patients? So again, a reminder that these recommendations that we have come up with are a method to assist in prioritizing. We looked at the preventive health measures and we said, this is overwhelming. If you look at the chart, there's dozens of different recommendations. And how do we pick out the ones that are important and important in a different way to our patients? And those recommendations is what you'll see on the website, as well as what we've tried to talk about today. And again, they don't replace any standard of care. They're meant to enhance it. I wanted to show you this as a final thing. Again, I find it very important to figure out ways that we can do this that do not overwhelm our clinicians. And even if our practice does not have an electronic medical record, there are ways to do these kinds of triggers and reminders on paper and to use Teams in order to be able to most efficiently get this done. So this is the health maintenance form that we use, and it's small, but basically what you can see from here is the green is things that the patient is up to date on and don't need to be addressed during this visit, and the red is all areas that need to be addressed. So the top left box is health maintenance reminders that need to be addressed, and the right-hand one is immunizations that the patient is due for, and the bottom left one is this patient happens to be a diabetic, so issues related to that. At this point, I'd like to turn the mic back over to Molly for any questions that you may have.
Thank you, presenters. I'll now begin the Q&A session. The first question is for Greg and pertains to one of the slides that was presented. Melissa asks, does the statistic about the life expectancy of people who are homeless being 30 years less than their house counterparts include families who live in shelter? And could you please share this reference? Go ahead, Greg.
Thank you, Molly. I must admit, actually, where I got this reference from was the National Healthcare for the Homeless, the Council's website. As alluded to at the beginning of this webinar, I'm actually trying to start a respite care, and I would go in to do to get documents and research and things of that nature. But every time I would log on to the website, it was just staring there at me as part of the introduction to the website, that the average homeless person dies 30 years before their house counterparts. So I apologize, I don't know the logistics behind that particular statistics. But in relation to families who live in shelters, there is actually, I believe, a specialized webinar coming up that focuses on, and it's from our families and children work group, that focuses on children and obesity in low socioeconomic areas and how they are actually dying before their parents. They're not living as long. So I don't know if that specifically answers the question, but that is what the origin of the statistics that I used in this presentation. And I will pass the mic back over to Molly.
I believe Monica has a response for this question as well. Go ahead, Monica.
Hi, I just wanted to add, this issue about our patients having a lower life expectancy was also addressed by Stephen Wang in Toronto, looking at Canadian data. And I believe he did use single adults living in shelter for that, and we can get that reference to you. And he found about a 10 or 15 year less life expectancy. There are several studies, 3 of them that I can recall, one done in Boston, one out of Pennsylvania and one from California, looking at the average age of death of individuals. Now, this is a little bit different than life expectancy, but in that data, for example, in the Boston study, we looked at death certificates and healthcare for the homeless data to see what age individuals died at and what the disease was that was related to their death. And in that data, the average age of death was 47. And we're actually, that was a study done in the 1990s, and where one of our colleagues is underway redoing that study to see if we come up with similar results again. But I think the profound, any of these numbers do highlight the profound disparity that our patients face. And sometimes individuals talk about, well, preventive care is hard to do in our patients because they're dying so young and they're dying of all these other things. But it's a really important message that, the number one cause of death that we see from cancers is lung cancers, which is related to tobacco use. And the number two is hepatocellular cancer related to alcohol use. So the prevention really does have a place. And it's really an important message for our patients when we say, we care enough about your health and we think you're going to live long enough for this to be an issue.
Thank you, Monica and Greg, for that response. The next question is a combination of a couple questions that we're going to direct to both of the presenters, but we'll let Monica answer first. So the first part of it is how many HCH projects have a behavioral health specialist full-time on site? And the participant is saying that this is a challenge. And the second part is what would you recommend if mental health screening services are available but not treatment services? So Monica, if you could answer first.
So it's thank you for the question, because it's a really important issue. Without treating the full person and the behavioral health issues that our patients face, there's no way we can successfully treat these medical issues. The patient that I presented to you who had schizophrenia, he actually was being followed by a psychiatrist but was refusing care. And it's only when he started getting treatment for his schizophrenia did he agree to take metformin. So we know the two are linked. I do not have the number of how many programs have a behavioral health specialist. I will say that there's a real discrepancy in reimbursement that Medicaid and other groups give for behavioral health services versus medical services, and that is one of the reasons why there are fewer behavioral health services available. It can be frustrating to screen for things such as diabetes, such as depression, and not have treatment options, but it does open up the opportunity for us to be able to do some basic behavioral health counseling and treatment for things like depression as primary care providers. I'll hand the mic back over to Molly.
Greg, same questions for you about behavioral health providers and mental health treatment services.
Thank you, Molly. And I kind of have a different perspective. We are a healthcare for the homeless program that's part of a larger FQ. So as part of integrating care and getting ready for medical home, all of our clinics have a behavioral health specialist on site, and that's part of a contract that we have with a local mental health organization. But prior to that, it was prior to having this service, which is a godsend because we can actually send for immediate evaluations, we didn't have any behavioral health access. And so I had to do basically the best I could as far as doing assessments and having staff up front do basic screenings and trying to implement medications that we have available as part of our pharmacy. Beyond that, in trying to also be able to deal with chronic health issues, we would do physical outreach to the streets and to the camps to follow up with the mental health aspect and try to then have them come in to the clinic so that we could do chronic disease management. Thank you, Molly. I will pass the mic back to you.
Thank you, Greg. Our last question is going to go to both of you, Greg and Monica. And Judy asks, we have a rotating homeless shelter in our churches in our town. I'm a parish nurse and would like to start a wellness program. Where should I start? Greg, I'll hand it back to you, and then Monica, if you have a response, you can go ahead as well.
Thank you, Molly. It depends on the resources that you have available. You can actually probably start, and if I had to do that here, I would try to set aside a separate time, maybe an afternoon, free from the clinical setting, in which I myself could, or the staff here could actually invite individuals into our group room. We have a group room set aside just to do education, and start with the basics as far as wellness, on taking care of your health issues, on working on proper diet, on smoking cessation, things of that nature. So you can start, I believe, on a very small level and increase those services based on the resources you develop. And I will pass the mic back to Molly.
Thank you, Greg. Monica, you can respond to.
I agree with what Greg's saying. I might add, Judy, that, one strength that you can look for is looking to see what community health services, whether it be through neighborhood health centers or through local hospitals or private provider clinics, are willing to engage with you. And a lot of times it's surprising how you may find providers, other nurses, other individuals who would be willing to give you some volunteer time to either connect patients to preventive services once you've engaged them, or to come to your site and provide some services, or flu vaccines or something like that. So I think starting at that level can be very helpful. And then also, as you gain the trust of the patients, asking them what they feel is something that they would like to see is one of the first things you start. I'll hand it back to Molly.
Thank you, Monica. The next question is actually for you and is about one of the slides you presented. Kevin states that you made a statement that completion of Hep C therapy is poor and that the need is to increase access to this treatment. And then he asks, do you think that the complicated nature of this treatment is more likely the reason for failure in this area?
Thanks for the question. It's actually a very, very important issue. So if you were to ask me just off the top of my head why patients don't get treatment for hepatitis C, I would say it's because of the unbelievable amount of side effects from treatments such as interferon. We have a lot of new treatments coming down the way, and I think it will become easier for patients to tolerate. However, if you the data that I showed shows that the first step where we're stuck is getting individuals to actually go. So only a third of patients, and that's in Boston where their services are very easily available, only a third of patients are actually seeing the specialists. So part of the issue is just getting them to the specialists, and I suspect there are lots of obstacles to that, including patients' inability to go to multiple appointments. But the other issue is that once they get to the specialist, will they be able to undergo the treatment or not? And we have used our medical respite to help some individuals during the initiation of treatment so that they can have a place to rest and deal with a lot of these issues related to the treatment, which can include some very horrific flu-like symptoms. And I agree, of course, that if we could prevent the number of hepatitis C cases among our patients, that would be paramount and very, very important as well. The other thing that we're trying to pilot right now is we just received a small grant to look at doing the hepatitis C treatments ourselves in clinic so that patients won't have to go to another site to get the treatment, and maybe that, getting rid of that obstacle and having people they trust within the primary care clinic, giving them the treatment and following them closely will have higher rates. But we've just started that program, so we'll have to see how that goes. I'll hand it back to Molly.
Thank you, Monica. And we don't have any more questions, so we'll go ahead and close the meeting. Thank you for joining the Addressing Key Preventive Health Measures in Homeless Healthcare Settings webinar produced by the National Healthcare for the Homeless Council. We invite you to visit the National Healthcare for the Homeless Council website for a full listing of upcoming and archived council webinars, as well as other educational products. I'd just like to say thank you one more time to our presenters, Greg Morris and Dr. Monica Bharel, and thank you to all of our participants. This meeting is now closed.